happy to and privileged to introduce Dr. George Kong, associate professor, and particular interest in glaucoma caused by angle closure and inflammatory eye diseases. Experienced in complex glaucoma and cataract surgery, in particular minimally invasive glaucoma surgeries. George has been awarded the prestigious Eberhard Dort Memorial Award from the International Society of Clinical Electrophysiology of Vision for his work on retinal electrophysiology, and has been instrumental in the development of the glaucoma optic neuropathy evaluation website, which has helped thousands of optometrists and ophthalmologists around the world to improve their optic nerve examination clinical evaluation techniques. He has been a co-inventor of software for visual field testing software on iPad, which all of us are aware as the Melbourne Rapid Fields. Thank you for being here, George, and all yours.
Thank you so much for the kind introduction, and thank you for the organizers for this opportunity to present in this forum. I will be presenting about Melbourne Rapid Fields, which is a software for portable visual field testing that I've been developing for the last 7 years. As you know, glaucoma, the incidence and prevalence of glaucoma is increasing with the aging population. And this leads to a lot of direct and indirect costs to the health system as well as to the patient. What we really would ideally want to have is to be able to concentrate the resources we have in the hospital for those who need it. And there is increasing need for patients to be monitored more in a community and possibly the home environment, rather than all coming back to the hospital for regular monitoring. As we know, the standard perimetry machines are commonplace, but they have downsides of being large machines. They're bulky, they're not easily scalable, and they have both an initial capital cost as well as a running cost. Also, they do not really facilitate increased communication. So what we have developed in collaboration at the Royal Victorian Eye and Ear Hospital and at the University of Melbourne is a sort of digital solution. Initially, it was an iPad app, and it's been an iPad app for a couple of years, and since the start of COVID, it's become a completely online-based system. That is device independent. It's a browser-based software. And we really wanted to develop a validated perimetry. Well, some of its features are that it is a web browser, and all you need is a 9.7-inch screen or larger to perform the test. And it achieves the 30-degree eccentricity that you require for, say, 24-2 or 30-2 test by changing the fixation point to the corners of the screen. It's a comprehensive white-on-white perimetry, 24-2, 10-2, and 30-2, as well as binocular estimate equivalent test. There is an integrated visual acuity test, progression analysis, and in terms of the testing time, the average time for the 24-2 is about 3 minutes, and 24-2 rapid is about 2 minutes. And we have 16 papers published so far. It is registered in with TGA in Australia, with New Zealand, and with the CDSCO. It's currently used by 370 clinics. And we have various options in terms of languages to guide the patient through the test. So quite often you don't need an assistant next to the patient. And there's what's rather new in the last couple of years is the better utilization of the webcam. You will use a computer machine learning or AI algorithm to assess the webcam to ensure that the patient's face is in the right distance away from the screen, because it is performed as it's a free space sort of test. You also ensure the background lighting is correct, and he also monitors for gaze stability by looking at the eye. In terms of the visual acuity test, it uses AI to analyze the hand gesture so that the patient can perform the distant visual acuity by moving the hand. The way it allows multiple different types of screens to perform the test is with a calibration system where there is a virtual ruler, and you match the virtual ruler against a physical object like a credit card, and that tells the computer what how to display the test. It does the white-on-white perimetry, and then it displays an output. The typical output shown here is a HFA against the MRF test, and you can see the typical sort of grayscale that it represents, the reliability indices, global indices, point-wise analysis, and the gaze stability tracking. In terms of binocular test, there is a binocular estimate equivalent, but it requires a larger screen. The idea is that potentially, so apart from having its use in the clinic, there is a potential for home-based usage, that patients could receive a personalized link, and they can perform this test using their home computer, such as a laptop, and then you can track for progression. How it compares with Humphrey, we've published a couple papers on it, and the concordance is quite good, and the test-retest variability is similar to the CETA standard and a little bit better than the CETA fast. And in terms of personal sort of patient experience, it's generally quite good, even compared to VR goggles. We have also have a couple of papers in review looking at the comparison with 30-2 and 10-2, and they are showing really good concordance. And the 24-2 rapid protocol has a similar testing time as a CETA faster algorithm. One of my collaborators, Dr. Shibal Bhatia, has personal communication found that in 97% of Hindi-speaking patients find that they agree with the ease of use of the software. A couple of studies performed in underdeveloped communities in Africa and also in rural Australia, showing that it has good capacity to diagnose and monitor for glaucoma. And this year we have been selected also as a value supplier for the IABP. In terms of home-based test, we are one of the first groups to look at how patients perform the test at home using their own using an iPad device, and show that patients were able to perform a visual field in a with similar outputs as the Humphrey visual field test, with correlations of 0.85 or so. And a similar study was performed in the age-related macular degeneration patients compared to the Maya microperimeter. So here are some of the publications, and 7 of those were international independent groups. Some of the how it compares with other types of similar technologies. Compared to Humphrey field analyzer, it has the benefit of being portable and it's scalable. So you could potentially have 2 or 3 of these running in your clinic in a perimeter room with so really speeding up your clinical output. It also has a unique offline mode and of course the AI eye tracking technology. So some of the research partners that we are doing research on, apart from the University of Melbourne, are across the world here. And we want to the future vision of the system is that it could hopefully also encourage better communication between sort of doctors and patients and allied health, so that the information can be easily shared between the treating the stakeholders to really help patients monitor their glaucoma and take control of their glaucoma. So in summary, it is a validated perimeter that is that is portable, and it can be used in any type of device. We do have a booth here in the conference this year, so please come and we can perhaps demonstrate it to you in person. Thank you.
Thank you, Dr. Kong. I think we'll take 5 small questions if there are. Is anybody having any questions, comments? I think the work is wonderful, and I think it's really expanded the use of perimetry for us, especially in smaller areas. Yes, ma'am.
Thank you.
I think this is absolutely outstanding, and I've never used this before or heard about it. Is it available online? You said it's available online. Is it for free, or is it a one-time cost? What is the...
Yeah, so there is the free test that you can perform and be able to see how it performs. We do have a distributor that is based in New Delhi, and they distribute the test, and it's purchased more like a virtual consumable, like a consumable. So yeah.
Anybody in the audience? Yeah, please.
Arthur?
Just closer to the mic, please. I think you're going to have to shout.
So I think for telehealth, it's in the U.S. There's definitely applications there. So one of the questions I had though is, luminance is obviously very important for any visual field test. How do you control the luminance, especially in devices that have light sensors and will adjust based on ambient lighting?
Yeah, great question. Now, with luminance, the good thing is that a lot of the digital devices, their screen luminance, they don't vary very much if their brightness is turned to a maximum, and that's what we recommend for the users when they start using the software on the device. They will turn the screen to a maximum. The slight difference, the differences in brightness across screens would affect both the background and the stimulus at a fairly similar level. So in terms of the contrast, actually the contrast ratio doesn't change very much. Probably within 3 dB, per point. And thirdly, at the start of the test, we do almost like an internal control where we display a stimulus during the practice test that the patient is supposed to be able to see within the fovea region. It's a very light sort of stimulus, and they're supposed to see it if the screen brightness is sufficient. And if they don't see any of that, then we recommend that their screen needs to be turned brighter.
Great,
Yeah, thank you.
Are there any specific environmental conditions that you advise the patient while performing the test, like specific room or other specifications?
Yeah, so just similar to standard perimeter, we recommend the patient would need to be in a darkened environment and no reflective light on the screen, and it needs to be a quiet environment. And even if the patient say if they are doing the test at home, then we have a sort of research assistant that guides them on the optimal location. And I envisage in the future, if it does require, if the telehealth does kind of take off, then there would need to be someone who would be guiding the patient at the start of their journey to ensure that they're doing it properly. But the webcam also does a little bit of the validation. The webcam actually detects lighting, environmental lighting, and actually suggests whether they need to be a little bit darker or not.
There are a few portable perimeters which are available, where they have a cap kind of thing that the patient needs to wear and can perform the perimetry. So compared to that, how is this better? Because in that case, they kind of nearly simulate an perimetry that we do in a closed room, dark room.
Oh, yeah, it's like the goggle
Yeah, it's
take.
like a goggle kind of
Yeah.
piece where you
So
goggle.
yeah, goggle tech is I think they're great too. There's a couple of disadvantages are in terms of acceptability in elderly. They are still questionable, and there are a couple of patients who get severe sort of dizziness from the virtual environment. In one of the head-to-head sort of trials in the Sydney Eye Hospital, there was a patient who was wearing the goggles. He went into a vasovagal also. So but it hardly happens with a tablet device.
We'll take one question. The gentleman, the ladies here as well. So short questions.
Very
Please.
briefly, is this system available for the hospitals to be used in sedative mode?
Yes. It can be. Yes. So hospitals can use this, and we, if you come by our booth, and we'll be able to. Some of my colleagues can help.
So it has to be purchased for the software can be purchased for mass use, is it?
Yes, it can be purchased as a consumable per use, or it can be a subscription. It's either. Yeah.
I have a question related to what the lady was asking. Have you got any adaptation that can be used on bedridden, lying down patients? Because a lot of times neurologists want us to do bedside visual fields. So
Yeah.
in a hospital setting, for IP patients.
Yeah. So I think that's a great usage of this. And one of the studies we have done was using iPads in post-stroke patients. And one of the optometrists in our research team went to the stroke ward and actually to do visual field on these patients, and actually detected 20% of previously undetected visual field defects in these patients.
Can you make it brief, because we are running short of time?
So
Yeah, so
then,
it is
Thank you very
possible.
much. Maybe you can
Yeah, so
have
like
the
a tablet,
discussion.
yeah, tablet.
tablet.
Yeah.
Yeah, thank you very much.